Well, this has been an eventful day with Zoom links. Or
I
not.
was just I was just apologizing and how Zoom does not want to be my friend today. So Kelly and I apologize profusely for all of the emails. We've got quite a few people coming in and out of the waiting room, so I think it's starting to get dispersed out.
Okay, thank you very much, Erin. We certainly will not hold you responsible for anything that happens in cyberspace, so.
Well, I appreciate that because I've been in
Nobody-
panic mode most of the day.
Nobody should be held responsible except the gremlins in cyberspace. How are we doing on voting members? I see Steve and Valerie.
I have Steve and Valerie as well.
Okay.
That's what I have.
Well, we need one more to have.
I think Mary's coming in. As soon as I get the waiting room cleared to go double check members, we get more, which is a wonderful thing. So
yeah. Okay. Thank you, Erin.
Good morning, Sheila, or it's good afternoon, excuse me.
Good afternoon, Mary. Glad you got the right link here.
I know, I was going back reading, I'll go, wait a minute, I think I got the right one, so. Evidently I did manage to do that right today.
Yes, you did do that. Thank goodness for Val alerting me early because I wasn't at my computer and I missed the early email, so.
It was just weird because when it came through, it said canceled. And I was, and I was like, what the heck? I automatically called Sheila, texted Sheila. She's like, no, it's not canceled. And I was like, that's the strangest thing.
Well, they had to cancel the link that wasn't working, so. And then it turned out that the new link wasn't working, so this is the newer link. So.
Were your ears burning today, Sheila?
I'm sorry?
I said, were your ears burning earlier today?
No, I don't think so, but maybe.
Well, I went to the Harbor House and anyway, they were talking about you and whatever. I said, yeah, about the rally and all that. I said, yeah, I said it went off wonderfully. So yeah, so we had nothing but kudos.
Well, thank you. It did turn out to be, for our first back in person, it was quite good.
Yes.
Thanks to all that pitched in there.
Yeah, it was definitely a team effort, but that's the first time I'd been out to their new building. I mean, it's very impressive.
And who are they?
Oh, I'm
Yeah,
sorry.
TJ can't get on. He has the wrong link.
I'll forward it to him now. Thank you. But outside of that, your waiting room is clear, Dr. Schuster.
Okay, thank you. All right. Who was that needed the link?
TJ.
TJ, okay. We'll give him a second to get in. Who does Harper House serve, Mary?
They serve Michelle P. waiver. They serve the SCL waiver and also home and community based waiver. So they have a really good program. They have some programs from seniors, and of course they see some of our folks, ABI folks, under SCL, but I was quite impressed.
Great. I'll have to go out there sometime. That would be good.
TJ said his link isn't working.
Right.
The new one?
I'm not sure.
I think Erin just sent it to him.
Okay.
Thank you.
I don't know if Kel's getting on or not. I'll check and see.
No, she was tied up. She sent me an email earlier.
Okay.
Yeah.
Okay.
Oh my God.
All right. Well, let's go ahead and get started because we're running a few minutes late. So thank you all for your determination to get on and join us. And thank you to Erin and Kelly for troubleshooting this was a Zoom problem, and apparently they don't like the Mac and some of the TACs because they have discontinued us. And so she found out early this morning. I guess, Steve, your reentry TAC
Correct.
was caught very quickly this morning. So thanks to Aaron and Kelly for continuing to troubleshoot and get the links out. And we do have a quorum of our voting members. Before we start, I think most of you have been notified, but I want to be sure that you know that we've lost Mike Berry, who had been a voting member of this BH-TAC from its very inception. Mike was a wonderful advocate and a great role model for people dealing with addictions, and worked to build the PAR group, People Advocating Recovery. He was the kind of guy that stepped in to do whatever was needed, always with a smile and good humor. He was a longtime treasurer of the Kentucky Mental Health Coalition. And way back when we used to have the 874K Disabilities Coalition gatherings over in the convention center, he used to be our announcer with that booming voice of his. He was a former TV reporter and person. If you could mute, please, mute your line. So I'd like to have a moment of silence as we mourn the passing of our friend and colleague, Mike Berry. So let's take a moment to think about Mike. Thank you very much. We wish him all the peace and love. And we're sure that he's sending us his guidance and good humor through all of our work. So we have the draft minutes were sent out from our January 11th meeting, and I would entertain a motion from one of our voting members to approve the minutes as distributed.
This is Mary Hodge.
Mary motion, and I think Steve was in the background with a second.
Right. I'll second it.
Thank you. Any additions, corrections, omissions, revisions? If not, all the voting members who are in favor of approving the minutes signify by saying aye.
Aye.
Aye. Opposed, like sign, and abstentions. Thank you very much. We do, and we sent this notice out. We did need to make a change in our May meeting date because I'm going to be out of town. So we've moved it to May the 1st. I think that's May Day in both the Russia and in the United States. And we'll be back to our 1 to 3 time because the legislature will thankfully be over by then. So it's May 1st, Wednesday. No.
Yes.
Wednesday, May 1st. Yeah. So if you would make note of that, and we'll send that out after the meeting as well. I know that Pam Smith is tied up at a conference, and I think we have Alicia Clark to give us a status update on the 1915I SMI waiver.
Good afternoon, you all. Can you hear me?
Yes, thank you, Alicia. Is it Alicia or Alicia?
Alicia, but I'll answer
Alicia.
to whatever. It's
Okay,
fine.
well, thank you. I don't think we've had you on with us before, but thank you.
You're welcome. So just to let you know that there were 18 submissions with public comment, but there was a total of 86 distinct actual comments of those 18 submissions. And then we are working to review and provide a response on that. We do have a meeting tomorrow to continue reviewing those comments. Once we get that completed, a full response to all those public comments will be posted.
You have any idea about the time frame for that, Alicia?
I do not, but I don't think that I don't think it'll take too long, but I don't want to give myself a time frame just because I have not talked to Pam
Okay.
about that, and I hopefully will have a little bit better information tomorrow after that meeting.
Okay. If you get any feedback from her, you might, if you would let me know, I could let people know.
Absolutely.
That would be helpful. And then the other part of our question was, what would the time frame be after you all submit the responses to the comments if you're going to do any revision of the SPA before it's submitted? So I guess the question is, when would you anticipate, or when would Pam anticipate that the revised SPA would be submitted?
Okay.
Okay, if you could ask her that as well.
Yes, I will.
Okay, great. That would be
Can I
great.
ask a question, Sheila?
Absolutely, Steve.
Alicia, how are you?
Good, how are you?
I'm looking at the budget bill that the House passed, and it has funding for a serious mental illness waiver and one that says the HCBS for individuals with serious mental illness and substance use disorder. Do you know what those two are? I mean, one must be this waiver.
Steve, this is Leslie. We can't speak to the budget, but I will tell you that we've got the 1115 SMI still pending at CMS, as
Okay.
well as the 1915.
Yeah, I'm not asking for this. I just want to know what they
I was gonna,
are in the
I
budget.
haven't, I'm not sure if that's what's going on, but that's probably what it is. It's those distinct two that we have.
The one says 1115 specifically, and I guess the HCBS is really the 1915I.
I think that's how
probably.
they designated it.
Okay,
Yeah.
just
And
wanna
of
make
course
sure.
it includes multiple folks though, but yes, I think that's what it is.
Good. That's all I want. Thanks.
Okay, thank you. And thanks for the question, Steve. Leslie, are you going to report on the status of the incarcerated persons waiver?
Yes, I'm going to do that. So good news a little bit. We did get some comments back from CMS. We did receive just a handful of questions. It really wasn't anything that was even worrisome to us, just very simple questions. And a lot of the questions were already identified in the application. We just had to show them where their questions were and how they tied together with the answers in the application. So that went really well. We have also met with them to develop a cadence. I think it's going to be a bi-monthly meeting now going forward. Bi-monthly meeting to discuss the reentry. And remember, it's the reentry waiver. It's no longer just SUD. We're going to serve more folks. So that's exciting. The opportunity actually is why the name changed to reentry. So CMS sent out opportunity in March and changed the name. Again, nothing alarming. Just wanted to remind everybody that you may or very soon will be getting an email that may be coming from Myers and Stauffer related to our Kentucky Advisory and Community Collaboration for Reentry Services. That's the long term for our new governance advisory work group called ACRES. So very excited about that. And the kickoff will be April the 17th. And I don't think they sent out the invites yet, but they should be coming very soon. So that ACRES committee will help us to, work on firsthand knowledge and feedback from stakeholders and sister agencies to talk about how we can coordinate that care for the individuals coming out of incarceration and coming into the community. There's several goals. I won't go into all of those things, but you all will learn about that if you participate in the ACRES work group.
And the ACRES is entirely around the reentry waiver.
That is correct. We
Right,
wanted to
okay.
do that to develop a governance committee that many folks in our cabinet, some outside, can participate on so that we can have feedback and guidance along the way.
Okay, and I will try to remember to change the name. I keep
That's okay.
talking about SUD services.
Everybody does that. It's okay.
Yeah. That's because it started out that way and
That's
we talked
correct.
about it for 4 or 5 years that way.
That's
So,
correct.
does anyone have any questions for Leslie on the reentry waiver? So, in terms of approval, this is where you go back and forth with CMS, right, Leslie? And as you answered their questions and so forth, at some point they're satisfied and then they give the approval. Is that?
Yes, we were very happy that they went ahead and reached out. So that means we're kind of starting down that road, right? So we'll start those ongoing. Again, the initial questions were not anything concerning at all, just how just trying to understand Kentucky's, what Kentucky's needs were. And we just identified most of it in the application, the answers in the application. So.
Okay, great. All right, thank you very much. We talked in January about behavioral health rate changes, and we know that there's a study going on, and they had hoped to finish their study and report at this meeting, but they notified us, Aaron, about 2 weeks ago, I guess, that they were not going to be ready for the March meeting, but they want to be scheduled for our May meeting. So we will have that report on the behavioral health rate changes. And is Bart Baldwin on? Bart, you had a question, I think.
I'm coming.
Did you want to go on and ask your question?
Yeah, there we go. Can you hear me now?
Yeah.
Okay. Sorry about that. I'm on my phone and the pulled off. So, yeah, and I think it was just in regarding to the update to the outpatient behavioral health fee schedule that's supposed to be updated for April 1st. And I was able to touch base with Leslie on this actually since you and I talked, Sheila. So, but I think it's still probably still a question for the group when we're going to see that, because I know that affects lots of folks on the call in terms of that bill off that fee schedule.
So Dr. Schuster, in preparation for Bart,
Okay.
Thank you, Leslie.
I did a little research, and so 2024's behavioral health fee schedule has been completed, and it was sent to Jeremy Drossett Armstrong, who is our liaison and our assistant director for the MCO, for the MCOs, and he submitted that to our MCO partners earlier today. So the MCOs now have it, and I'm already receiving feedback that they are confirming that they have received it. I know a lot of folks are going to be asking questions, so I ask for a little bit of statistics for you. There are 46 codes that had rate increases. I don't have those listed for you right now, but there are 46 codes that had rate increases. Any rate, a CPT code from the Medicare Kentucky specific fee schedule, which that's what we look at, every year, that was decreased, we did not change. We left it the same. So the rate remained the current rate. So there are no decreases in the fee schedule.
Well, that has to be good news. Yeah.
So I hope I exceeded expectation.
You did. Thank you, Leslie. You did. Good job.
Well, anytime that there are no decreases and there are increases, that's a good thing.
Well, it wasn't just my decision. Commissioner Lee and Veronica and all those folks, Deputy Commissioner Cecil, were all involved, and that was the decision that was made. So I will tell you, though, that at least 46 have increases.
Okay.
Good. And the MCOs all have it as of today. Is that what you said, Leslie?
Yes, and I'm already receiving confirmation back that they have it.
Great.
Jeremy's already sent it. Yes.
Okay. Thank you, Leslie, very much.
And then, is it posted someplace, Leslie?
It will be very soon. If it's not now, it will be very soon.
Okay.
And I think Bart may have said this, the effective date of the rate change is April the 1st.
Okay, an effective date is April 1st. Great. Any questions from anyone in the group about the behavioral health fee schedule? All right, hearing none, we'll assume that you did an excellent job, Leslie, and answered every potential question. The next issue is an update on the plans to expand the use of behavioral health associates, other behavioral health provider types, in addition to the community mental health centers.
Jonathan, are you on?
Yes, good afternoon, everyone. Jonathan Scott, Chief Legislative and Regulatory Officer for DMS.
Okay, what can you tell us, Jonathan?
Sure. So we have recently filed and amended after comments and a statement of consideration of both 907 KR 15005, which is our definitions reg for all of Chapter 15, which is our behavioral health services organizations, our CDTCs, our MSGs, just a lot of the non-CMHC, non-FQHC, non-RHC behavioral health providers in the Medicaid program. We're also added these changes into the CMHC regulation, which is 107KR 1044. So both of those were filed. We were proceeding forward with a general change so first of all, the BHA is replacing the MHA and the CMHC regulation. And then we are also allowing them to practice in some of the behavioral health providers in Chapter 15 as well. So we filed the reg we filed the statement of consideration, realized that we needed to have a couple more stakeholder meetings. So we're going to meet again with the CMHCs tomorrow, and then we're going to have another stakeholder meeting next week. We're still trying to iron out some issues that are surrounding the amount of time that a BHA can be in the program, participating as a BHA without progressing on to licensure as a licensed person. We have the changes that are in the reg as of right now is that the BHA needs to be in a graduate level program, needs to be participating in an internship or practicum, or have arrived at a point where the school is willing to risk their accreditation and say this student is ready to go out and practice. And then we also have specified that a BHA can't render a diagnosis for a client. So going forward, I think there's going to be a different code put on our fee schedule that they'll be able to build. It'll be more of a counseling code. So it'll still be the same reimbursement. They'll still be in the program, but we're going to be taking just a single step back on that psychoanalysis piece. And I may be talking too much. You all may want to get to some questions too. So I'll stop there, and we can keep talking.
So what
This
happened?
is Steve Shannon.
Yeah, go ahead.
I appreciate the opportunity to discuss this going forward. We obviously CMHCs, I mean, the CART members have concerns about the transition and just the overall implementation of it. I'm not surprised that licensure boards, when they were asked, I would suspect they would have had concerns about this, but just again, we've been using these. I tell people I've been here 27 years. They were here before I was. We've been using MHAs effectively in monitoring their performance, and all those things we take seriously. But I do appreciate Medicaid openness to a discussion about what it looks like and the utilization patterns and what takes place. I've always had some concerns about the time frame, and that's not a surprise to you. 60 credits in 5 years going part-time is you can't have a hiccup. You can't have something take place and still be done. There is a mechanism for an MSW and 30 if you have a BSW, but there's still some debate if that gets you to licensure status, because most licensure requires that 60-hour program. But still, we do appreciate the opportunity to have discussions about this. So thank you for that, and Leslie, thanks for that, and we'll see how we proceed from here.
And I did want to emphasize that we are committed to keeping the BHAs, and the MHA structure that they're replacing. We do strongly believe that this needs to be a part of the Medicaid program, that they need to remain, and that this is an important way for people to get experience, for providers to possibly extend what they're doing a little bit. So they are an important part of our behavioral health system. We want to keep them in there, and so some of our changes we saw as a way to preserve this, to make sure that there isn't a grounds for any individuals, whether they are already practicing or not, avoid any trouble with their licensing boards. So I agreed, Steve. We certainly want to see this continue with just some we want to see the BHA MHA program continue in our system for sure.
Good to hear. Thanks, Jonathan. We're okay with guardrails, some direction. We're fearful that we are going to go to 0.
Are there any other questions from anyone in the group? This was a topic of some heated discussion back in probably November.
Yeah.
First came up, and I think there were a lot of people that were either alarmed or relieved or happy or sad about it. So this is a great chance with the guru here, if anybody has any questions.
There were many feelings that have been felt about this on several sides as we've gone through.
As fits behavioral health, I guess.
Yes.
I have a question, Jonathan, and I have to say I haven't studied the new reg, but when you talk about practicum or internship, you know, when students first get into a
Right.
master's program, they typically don't have any practicum until they have a skill. And it takes some coursework to get a skill. And very often, particularly in a part-time program, a student might go for 2 semesters easily, maybe even 3 semesters in some basic, for instance, in psychology, you would have some basic psychopathology courses and that kind of thing, and the rubrics of diagnosis and counseling before anybody feels like they would have a skill. So I guess I'm curious about what happens with BHAs. I guess everybody's going to be called a BHA during that period of time.
So it may not click on. They may be functioning as a different, it may not click on for them to be a BHA until they have those skills or they've entered into a practicum. A lot of this is going to be between the school, the provider that's supervising them, and the facility that they're at. It's conceivable that schools may design a practicum or an internship program that can be entered into a little bit earlier, especially for certain individuals with certain levels of experience. But at some point, it's a little bit out of our hands, and so we're leaving that a little bit open.
So it would be worked out between individual universities and individual programs within those universities.
Yes.
And the comp care centers or the BHSOs or whatever.
Yes,
Is that what you're saying?
Yes.
Yeah, and that's a challenge for us, Sheila. Think about it.
Sure is.
The number of online classes, back when it was in person, you could probably figure out, 8 to 9, 10 universities in Kentucky, but with online, and I've raised this point, there's essentially a churning mechanism that, I'm not eligible to do what I have been doing. And then when I take this, internship or practicum experience, I then am eligible. So there's a gap in what those folks can be doing for that period of time. And that's really impacts the existing cadre folks, there wouldn't be new cadres essentially.
Yeah.
There wouldn't be. So I think that's a concern that I've expressed to Jonathan already. And I've often wondered what schools will say, yes, this person can do that before they finish their program. I would think if I was a school administrator, my rule would be if you haven't finished the program, you're not eligible yet. We think all courses are important, not some. So I think those are conversations we can have in those future, stakeholder meetings.
Oh, and we are our system. You're going to just click on to being a BHA. You can't. Like if you have a practicum your second semester and you have a couple more semesters left after that, you won't click off. You'll
still be.
We will be clarifying the reg in next, but before it goes before ours again, as to that piece. So there's some wiggle room for some clarity here that we're and
maybe there's kind of a parallel tracks for the existing cadre and then the new folks, so maybe that would be a place we could settle on.
Well, and David Crowley from Anthem put a note in, how will the MCOs know who's billable, who's reimbursable.
Well,
They're not licensed or associate.
I'm sorry. You want to ask that question, David?
I couldn't hear that.
Sure, I was just making a comment that it's even more challenging for the MCOs to verify any of that information, because that's communicating
Oh,
with
to be eligible, yeah.
right. That's, but that's for later discussions, I'm gonna assume.
Yeah, we can have the operational discussion internally as we get a little bit closer to all of this.
David, just call me and I'll tell you.
All right, got you on speed dial, Steve.
All right. Any other questions for Jonathan? And we appreciate your being on, Jonathan. We may have you report back periodically as these discussions go on. We do appreciate your extending the opportunity. So Michelle says, how do they do it now with the MHAs? You may be able to answer that, Steve. How's the billing done?
There's a code for MHAs. I think the real question is, when do you become eligible? Now there's not that you must be in an internship. So, the CMHC
Exactly.
determination, they're an MHA, and that's the determination's made, and that's what they do. But someone who is in the process, does Anthem need to know they have a practicum? Therefore, they're now an MHA, right, David? Is that a fair question?
Yep. Yeah, exactly.
And our behavioral health team and our MCO team will be giving you further guidance on that as we go a little bit farther. But that's not reg level discussions. That's going to be fee schedule and modifier discussions that will happen on the billing side as we progress a little bit farther.
Jonathan, this is Angela.
Yep, there we go.
Sorry, I'll jump in. Again, I think that initially, David, what we had spoke to was an application process through the department. I think again, we'll have to review that and tweak that based on where we land in the final outcome. So again, I think initially it was the individual would apply through the department, be approved for that BHA status, and then again utilize the modifier, the appropriate modifier. But again, we can revisit that together as we kind of see where it lands.
Sounds good.
Thank you.
Thank you, Angela. Yep.
Yeah, it's tricky. I know in Tom James says we'll need criteria for credentialing so claims could be made. No parity. There's nothing on the physical health side. Is that what you're saying, Tom?
Yeah, Medicare has some extenders that, do some that they bill under the physicians. But, again, this is something we've been doing a long time. MCO has been paying us a long time. I think the distinction is the eligibility piece is now added to it, that you must be enrolled and have a practicum. I think that's going to be the real challenge for everybody to get to that place.
Agreed.
Yeah, I was
Yeah.
going to say, from a licensure standpoint, I remember being on the board of the licensure for psychology, and the exemption from having to be licensed was that you were in a university program and enrolled for credit, but it didn't get down to that level of what courses were you taking and were you taking practicum and so forth. And this is a much finer point on that. And it would be something clearly that will have to be worked out with the university programs so that everybody knows, because they're probably called different things in different places. That's the other problem you get into. So thank you very much.
More to come.
Yep.
Absolutely. Thank you, Jonathan. Do we have a report? Excuse me. Justin Derringer on the website dashboard. Excuse me.
I don't see Justin on Dr. Schuster, so I can follow up on that, unless there's someone else on from policy.
Excuse me. Okay.
We'll follow up on that for you, Dr.
All
Schuster.
right, thank you. Pam's not on. I don't know, Alicia, if you're prepared to talk about the 1915C waiting list numbers.
Yes, I can give those to you. Would you
Okay.
like to share my screen? I do
That would
have,
be great. Yeah, if you can do that.
I
you
do
can-
have some additional kind of numbers instead of just the basic. So let me,
You should
try-
be a co-host now, Alicia.
okay. Let's see. All right, where is the share my screen on this one? Oh, there it is. All right, let's see if that comes up. Can you all see it?
Yes, we can.
Okay. Here I will. Okay. All right. So just to let you all know that there are 11,008 unique individuals on the SEL and Michelle P. waiver waiting list. Couple things that aren't on here that I will tell you is we do have 43 people that are on 3 waiting lists. We also have 1,642 that are on 2 waiting lists. But 4,580 people that are on waiting list are in a waiver. And then of the 6,428 that are not in a waiver, they could be receiving other services, such as through EPSDT. So I know this is kind of a lot to look at, but we did, like I said, the 11,008 is the unique individuals that are both on the SEL and Michelle P. waiver waiting list. And then you can see right here, the ABI has 2, and we have HCB. But I just thought this kind of gave a better representation, because we do have a lot of duplicate individuals that are on multiple waiting lists and that kind of thing, or that could be served under other services through state plan. So I wanted to share that. Is that helpful?
Alicia, this is Mary Haas. I can't see the ABI numbers on my screen. Can you give me those
Yeah.
2 numbers, please?
There's 2 on ABI, sorry, and I just tried to make it a little bit bigger for you all, but it kind of cuts out a little bit. But you have 2 ABI that are on the wait list.
Is
And
that
this
the
is-
long-term, that's the long-term care, correct?
Yes, yes.
Okay. Yeah, because I know of one of those, so that clarifies for me. So thank you.
You're welcome. And that is information as of yesterday. So again, these numbers could have changed. We could have allocated somebody, or there could be, another person or 2 on the waiting list. But that's as of yesterday when we pulled it. And I have to give props to BHDID. So Kathy, I work with her a lot on, the other waivers as well. So she actually had this for another presentation that we needed to do. So I could just kind of bring this over. So I appreciate her work on that.
Alicia.
Can you get a copy of that?
Yeah, that's fine. I can send that out. Or I'll give it, Aaron, can I send it to you?
Yeah,
I've
Aaron.
already sent you a message requesting it, Alicia.
All right, I will send it. And then
Alicia, the 283, tell me what that is. Where it says HCB 283. They're
So,
only in the 28, they're only in the HCB waiver.
so it's waitlisted, but they're in more than one program, like
Oh,
including.
okay.
Yeah, that's
So they're
why
on multiple wait lists. That would mean that
I'm sorry, say that again.
that 283 number, they're on other wait lists as well.
Yeah, they're only waitlisted, but yeah, in more than one program.
Okay.
But I'll send this to Erin, and I will have her send that out to you all.
Okay, thank you. Any other questions from anyone?
And I will stop sharing so I can give that back. Hopefully I'll do that correctly. There we go.
Sheila, this is Mary Haas.
Yeah.
Question to Alicia. You said on the two that were waiting, you didn't know the status. Have we implemented where they don't have to wait till the following year? So what would
No.
be the two could be just during the process, or do they have to wait till the following year to get the allocation?
Yeah, the next waiver year, right, Mary?
That's
Because
what
they
I'm
get
talking about.
services
Yeah.
now as opposed to having wait to the beginning of the waiver year.
Correct. And I can't remember with the ABI long-term and if that's July or if that's January. That's why I asked it the way I did. But yes, you're correct, Steve. Thank you.
So when you say wait to get services on the next waiver year, if we have a slot that has opened up, we can then allocate that slot to that individual. So I don't know if you are aware, but if somebody is unfortunately deceased, we can reallocate those slots. Or if we allocate to an individual who never decides to either get Medicaid eligibility or they decide that they don't want the waiver, as long as no services have occurred, we can then reallocate those slots as well.
Thank
that-
you. Alicia. That's helpful. I didn't ask the question exactly correctly, but that you answered it for the information that I was wanted, that I can go back to the person. 'Cause unfortunately, the person's in a homeless shelter right now waiting for services. So anyway, but that's helpful. So I can go back and answer those questions for the case manager.
Okay, thank you, Mary. And Mary, just to let you know that I just said Michelle almost. Pam, I don't know where Michelle come from. Pam said that she could not find where you had sent her another email about the access to the therapy services and ABA. So if you could send that to her, I think she had requested that after the last TAC. So if that's still
Okay.
a question from you,
I'll-
if it's not,
I'll-
that's okay.
I'll have to go back and check my emails and things because it was my remembering. I thought I did send that to her, but I'll go back and because I know we'll be getting more questions on the therapy services because of the last memo I got that they will be transitioning to the state plan May 1st.
Yes, it should be extended state plan.
That's May 1st.
We're
And-
expecting that the waiver applications will be, the new ones will be approved as of May 1st. And I know we sent out a letter on that, I want to say a couple weeks ago, at the very beginning of March, to give individuals 60 days, asking them to, start looking. And we've been actually, even on some previous webinars, we've asked people to really look at going back to pre-pandemic services, units, all of that, except for, obviously, there are a few things that we did in the webinar that we inserted into each application. But to give people, make sure that they had 60 days if they hadn't already transitioned. And then some of the providers might have even already gotten phone calls about those services that we run reports. And so I know that Dale's been reaching out, Karen and her group's reaching out, and BHTID has been reaching out as well, just trying to give that extra, notification, because I know sometimes people don't always read things that we send out. So trying to assist them and just make them aware.
The questions I am getting, or not so much questions, the concerns I am receiving from several providers are how will they be able to keep the specialized services that they're receiving. It's going to be difficult when you're going to have to get someone start fresh and you've had someone you've been working with for a couple years, how you're going to be able to keep the continuity of care and actually keep the highly specialized services, because some of these folks have 10, 12 years experience working with ABI, and you take someone who's not used to working with our clientele, that we're very concerned about the continuity of care, the quality of care. So I think, Pam has assured me this is going to be a transition, a process in the transition. So I think getting as much information out to the providers that are not providing care under the state plan, just providing it in the waiver, it would be very beneficial, because I think there's a lot of concern, and mainly this is how our folks get better, and it's causing us a lot of concerns.
Are you talking about the therapies in specifically? Is that what you're referring to, Mary?
Yes, Alicia.
Okay, all right. Just wanted to make sure, since there's so many waivers and the Appendix K and all of that, with, there were services that were put into place that were not normally. Yeah, I understand what you're saying. And, we've been telling people, a lot of the providers, get your state plan numbers. A lot of them have the state plan numbers, so they can really just bill under state plan. Unfortunately, a lady with a provider told us that it was more lucrative for her to bill through waiver, and that she would continue to do that. So, but it's really, I keep preaching that it's all about the participants and their needs. And but a lot of people have already gotten those state plan provider numbers for therapy. So that makes me happy as well. But I will pass along that information. I know you said you'd already talked to Pam about that, but I will let her know that that's still a concern for you. Thanks, Mary.
Thank you, Alicia.
And Mary, you're going to follow up with the email about the ABA intervention?
Yes, Sheila.
Well, okay, great, thank you. I guess this is you, Leslie, implementation of the delivery of mobile crisis services in Kentucky, and we're still concerned about the impact of budget cuts, because I think both the House and the Senate took out the mobile crisis numbers.
So first of all, I'm not going to be able to talk about the budget. The final budget's not complete yet, but we are still continuing to move forward right now. As far as our implementation goes, we are very, very busy in lots of individual, group meetings, contract meetings, policy meetings. We've completed all of our individual meetings, I believe, with the CMHCs and the CCBHCs, and we met with them first as the safety net. We've started individual meetings with our MCOs. We have regular weekly cadence meetings with our MCOs now. And we are working through lots of things that have to be done ahead of time. So we're working through contracts and policies and expectations and timelines and things like that. We've drafted policy guidelines, Dr. Schuster, this is important, for services, and those will be coming out. I think they're finished today, but we don't have them completely approved. So within probably a week or two, if not sooner, you'll see an all provider letter that goes out talking about some more in-depth policy guidance about the services that mobile crisis that you can provide through mobile crisis. And then I also would like to say the community co-response grantees. If you remember, we had 6 in our cohort 1, and I'm been very proud of them. We've got Boyle County Fiscal Court, Christian County Fiscal Court, Cynthiana Police Department, Lexington, Fayette Urban County Government, and then we had Maysville Police, the Perry County Ambulance, and the Warren County Sheriff's Office. So we've been very proud of them for stepping up to the plate to try to help us with this epidemic that we have across Kentucky as well as other states. They have received their first planning grant allotment, and DMS hosted the first in-person. We did allow for it to be hybrid, but it was exciting having all of them together in person in a meeting in Frankfurt this week. And then I just thought it was a great kickoff. So you probably see some social media coming out about that very soon. Our plans right now are still to have a second round in the fall, a second cohort.
And the implementation date for the mobile crisis is
Currently right now we're looking at June.
this June.
This June, yeah, that's what we're
Wow.
looking. Yeah, we've already started conversations. We've actually had several CMHCs and I think at least 2 of the CCBHCs that are stepping up to the plate and they're like, we're ready to go. So hopefully we can get more on. They continue to work. I can't give this to you today, but I want to be able to provide you with a heat map fairly soon of kind of where probably closer to June though, of where we know we're ready to go. So we will be working with the CMHCs, the CCBHCs, the BHSOs. We have a couple that are already providing some mobile services, and then we'll go out to all interested providers that can meet the provider type. And I can give you more information about that later, but everything so far is moving along. So we're very excited about it.
Okay. Any questions from anyone about mobile crisis? And we don't know what the impact of the budget cuts will be. And it is true, we don't have a final budget, but not a good sign that it wasn't in either the House or the Senate budget, I think. All right.
Dr. Foster, Patty
yes.
put Patty put a question in the chat, and it's about the CIT training. Let me get back to you on that, Patty. When we met with the co-response group this week. We specifically had EMS asking about is the CIT training something that we need to do, or what type of training should we do, because so much of it is around law enforcement, right? So we just took that question back just 2 days ago. So let me get back to you.
Okay, thank you. All right. Status of Medicaid unwinding and recertifications.
Good afternoon. This is Veronica Judy Cecil. My favorite topic.
Your favorite topic. I hope it's your favorite since you keep having to report on it. So
it is. And sometimes people look at me strangely because I'm too excited about it. Okay. Just to throw out a couple of numbers in, let me go ahead and put a plug in for our stakeholder meeting, which is next Thursday. And if you're unable to attend, you certainly can go online to our website afterwards and find the recording, because we record it and share the slides following the meeting. So just here is the newest information, updated information. The slide looks a little crazy, so let me walk through it a little bit. On the left-hand side are the original CMS monthly reports that we're required to file with CMS to let them know of each month of renewal and the approvals and terminations in various buckets and the pending. On the right-hand side, we are now required to update those CMS monthly reports with the activities that occurred around the pending cases. So if you see a pending case on the left side, let's take May, for example, we reported 2,698 pending cases in that CMS monthly report. We processed within a 90-day period following May 2,659 renewals. And so we report on the right-hand side in the updated monthly report what the outcome of that pending processing was. So you notice the numbers change as you move from left to right for each month because we're putting in the pending outcome in the appropriate bucket of approval or termination. We still have some pending, and sometimes that occurs because the complexity of the case, there might be a lot of requests for information that's going back and forth and just trying to get the redetermination correct. So there are still some pending, but they are prioritized by age. So we do stay up on those to make sure that they're getting processed appropriately. So I won't walk through these numbers. You'll get these slides. We'll also post it to the TAC website, but it'll be sent out to the members. But as you can see, I mean, I think what's always great to see is the approval number go up, even if it's small. But that's what we're tracking is trying to appropriately determine people eligible and keep them covered during this period of time.
Veronica,
Yeah.
why are the pending numbers, why have they dropped so precipitously from the early numbers? You're in the
Ooh.
thousands through August, and then you get to September and October, and you're down to 16 and 15.
Very observant of you, Sheila. What we started to do in September is redistribute some cases. Couple of things happened. So one was the child flexibility was put into place. So we automatically renewed children, which means we did have less cases that may pend. So, we moved all the child cases each month automatically. We also attempted ex parte or passive renewal on the population. And if we were unable to approve them, we then moved them or redistributed them. And we did some of that for workforce to try to help with the workforce. So that resulted in less pending cases because we were able to either proactively, and you see our approval numbers, that's sort of bears out in the approval numbers. They are also higher because we did have less people that were terminated for procedural reasons.
Okay,
So
that's all good news.
why, yeah, absolutely.
Yeah, great. Thank you.
Yeah, absolutely.
Phil, I have a question.
Yep.
Is this impacting folks, Veronica, in waivers as well? 'Cause I get questions about folks who are losing eligibility for their waiver.
So only if they're Medicaid, eligibility, so they do go through a renewal, and the majority of them. So there are some cases where if they're SSI but if they are, if they're Medicaid eligibility and the waiver, we do a renewal on them. So they are subject to renewal and have a renewal.
But they're not part of unwinding necessarily, right?
They are. Yep, they
Okay.
are. They have an annual renewal just like anybody else.
Right. Yeah.
Yep. And I say just like anybody else, there are exceptions to that, of course, because this is Medicaid. If somebody is categorically eligible, let's say there's a child in the welfare program, they're out of home, then that, they get granted Medicaid as a result of that, and they don't go through an annual renewal. As long as they're still in the welfare program, then they maintain their eligibility, and that doesn't change until they are no longer in the welfare program. Same thing for let's say pregnant women. They are granted that categorical eligibility based on being pregnant, meeting our income requirements. But once they lose the pregnant, they are no longer pregnant, then that's a categoric eligibility that they're no longer qualified for. So those are folks who don't have an annual renewal, but everybody else does. So
right. Even if you're in the
SEL,
you have an annual, right? Your situation hasn't changed. I've been hearing they're losing their Medicaid, but not their SCL.
If you lose
I thought those two were linked.
Yep, they are. Yep. So that would be unusual. I would like to see some examples.
I've heard that from a couple of different folks. That's the
Yep.
fear they're having, that they
Sure.
lose that eligibility, the Medicaid, really for the physical health piece, but they have no information on whether their waiver status.
No, they're tied together. You can't be in a waiver without being Medicaid eligible. That's correct. The eligibility requirements are different for somebody that is determined their level of care. There are some different eligibility requirements for them, but they still have to be Medicaid eligible. So, so yes, it is impact. We are seeing long-term care and 1915C waiver members drop as well, and including not responding to a notice. It's a smaller population, but it is happening because there's a lot of support and outreach going to those individuals. We're working with the case managers and the providers to make sure that they know that they're going through a renewal and they have to respond to that renewal packet. And so, if they don't respond, they will get terminated. Now, there's a level of care, that's tied to their eligibility, and that as you all may remember, I think we had some issues where we were extending the members' eligibility, but not extending the level of care. Those are, just some of the nuances to the eligibility and the complexity, to be honest with you, of the eligibility, both in long-term care and 1915C, that we've had to try to navigate.
Veronica, you may have mentioned this already, but a couple of cases that Pam and I have been trying to do some individual, trying to figure out what's going on, were people who we carried through the COVID period and they became adults, but we were still carrying them. And so they had additional determinations they had to do as adults. And so that's one of the things that we've been seeing.
Yeah. And we know we have people that came in under the 3 years of the public health emergency. They've maintained their eligibility through that. And now their circumstances have changed, which is the reason for the states having to go back to doing an annual renewal. So, it's true. And so we're really trying to identify those individuals and provide them as much of support as we can to understand. For example, if somebody turns 18, they have to go apply for Social Security, whereas under 18, their disability determination was different. The process was different. So just helping folks understand how to navigate that, is really why we've tried to do our best to make sure all stakeholders know what's going on and can help us with that member moving through the process. So numbers, obviously the most recent is February. And what we're looking at, we had 93,000 individuals go through a February renewal. We had 64,789 approvals, 10,105 terminations. The extended bucket is high because we are granting that 1 month to everyone, up to 3 months to long-term care and 1915C members to try to complete that renewal packet and get it back to us, doing what we can to help them with this, providing additional time for them to respond. And then tracking statements here on the right. We already have 963 that have come back in for February, so that's great. But we are tracking those numbers because there's a 90-day reinstatement period following a member's termination. And if they just reach out during that period of time, we can automatically, without them having to request it or take any additional action, if we can determine them eligible, we can automatically reinstate them back to their termination date with no gap in coverage. Any questions about?
Would that be the same for people that have been incarcerated?
So incarcerated individuals who re-enter, their Medicaid is suspended. So as soon as they are released, their Medicaid should kick back in. Unless they've had a change in circumstance, which doesn't really happen too much for those individuals. So their coverage would kick back in. They would eventually have a renewal. And so they have to, make sure that they're watching for that. But hopefully I answered your question. Okay.
Yes, thank you.
Okay.
This is Leslie.
Okay,
I'll just mention one more thing. So if you have an individual, I just wanted to mention this because people reach out to me all the time. If you have an individual that you're having trouble going after they have left incarceration, just let me know. We have a person, Jordan. She's just absolutely wonderful and has been helping me through all those cases, but they've definitely slowed down. I think I mentioned this before. I used to probably have 6 a month and now I'm probably down to like 6 a quarter, but just in the last couple of weeks, I've had 3. So if you all have somebody that's having trouble getting out of the suspension category, just let me know and I'll work on those for you.
Fantastic. Thank you.
Hi, Tim. How are you? Sorry, I didn't see your face.
I'm hanging in there.
Yeah, and to Leslie's point, so each of the jails and state correctional facilities are in sort of different places in terms of the support that they can provide to somebody who is being released. Some are really on top of it and make sure that person's covered, as you know, before they walk out the door. Others don't have the capacity to really provide that support. So we definitely want to help folks coming out to make sure that they have that coverage immediately, so they can get connected to services. And with the reentry waiver, that will work so much better. Any questions about this slide?
The reentry TAC is eager for the reentry waiver.
I'm certain, Steve. Thank you. We all touched on this a little bit with the in talking about the waivers that we're anticipating final approval from CMS for a May 1st effective date. As Alicia noted, there's separate communications going on around this and how it impacts the flexibilities that were implemented under Appendix K. So if you have questions, you know, there's lots of information out there. We're trying to keep it updated as much as possible, but we do have this email address or phone number. If you have a particular situation that you have a question about, you know, please feel free to reach out. We know this is a difficult thing to navigate, and we don't want people to go without answers to their questions.
That's very helpful to have an email address and a phone number. I think.
Absolutely.
Veronica, I appreciate that.
You're welcome. That's Pam and her
Pam
team.
and her team. Yeah.
They're doing, yeah.
Because
They're
those
really trying
questions,
to,
those questions
yeah.
come up all the time, and I'm not sure I realized that there was an email address and a phone number particularly, especially for them.
Absolutely. We'll do our best to answer those questions. And then just a reminder to everyone, regardless of where you are, if you're a family member, if you're a member, if you're a state, if you're an advocate, if you're a provider, we've got a lot of resources out there to help try to fill in the gap of information on various topics. The most recent one, I think November last year, we did one on ID proofing because we had a lot of people tell us that members were having trouble navigating how to create their account on Connect and running into some problems. So we offered some tips on what you can do and where you can go if you're having trouble. So lots of information. We're always encouraging people to post this if you're a provider or an advocate and you have members come in or you're interacting with them in any way, to share the tip sheet or the flyer to help people understand what's going on. And also to reminder to providers, so in Kentucky Health Net, you have access to the members' redetermination date. If there isn't a date on there, they're one of those categorically eligible individuals. They don't have an annual renewal, so just remember that. If you're long-term care, you can get that information out of the Kentucky Level of Care System clocks, or if you're a 1915C waiver provider, you can get that out of the MWMA. And this is our website, so just making sure everybody has it, but lots of robust information on it to help keep people informed about what's going on in Kentucky. I did the shameless plug for the stakeholder meeting next week already, but I do want to just ask, I say it all the time, if you're not following us on one of the social media platforms, Facebook, Twitter, or Instagram, Twitter is X, of course, then, you know, just like or follow us on one of them. You don't have to do all three. We share the same information across all the platforms, but it is the quickest and easiest way to find out what's going on in unwinding, if we have news alerts that we need to send out, or just to keep people updated on what's happening. We're using those resources. So I will stop sharing there and take any additional questions.
Very good. And you'll send the slide to Aaron to get them out.
Absolutely.
Will you, Veronica? Thank you. Any questions for Veronica? She wants to talk some more about her favorite thing, so this is the time to ask. Anybody? Okay, and where do people get those flyers? Is there a link on the PowerPoint that you're sending out?
So the link goes to our website, and our website
Okay.
has a place for communications. So you can go directly down to where the flyers are.
Okay, because I do get that question from time to time. And you have them in English and in Spanish at this point.
That's correct. Yep.
Wonderful. Okay, great. Thank you very much.
You're welcome.
Update on tracking Medicaid billing for mental health services to students. And if Justin's not on, I think he's typically the one that reports on this.
Yeah, and Sheila, let me apologize. So
Oh.
he is testifying today, and
Oh.
it has taken more time than he had anticipated. He thought he'd be available for the meeting. I think he
Erica Jones is on.
Great, Erica.
Oh, great.
Hi, good afternoon. Yeah, so we do have the data for the schools that are local education agencies that are doing the billing for mental health services through the school-based services program. And we also have the data for contracted providers that are billing in the school-based setting, that place of service 03. We have identified that there are some gaps in the data based on how providers are billing those contracted providers. But again, we do have significant data. And if that is something that we are, if the TAC is wanting us to share the specifics of, we can do that. But we do have a method to track that from now on.
Oh, that's really good news. So you have it, let me see if I understand this, Erica. You have it directly from the schools that are billing directly, and then you also have it from the contracted mental health providers like the CMHCs.
Yes, if they're using that place of service for schools,
Okay.
yes.
Yeah. Wonderful. Let's have you report, and let me see how much time we need on the BH rate change study, because that's going to come in May. So if not in May, maybe in July.
Okay.
And I will get back with you. We ought to be able to get some estimate of the time, but that would be great.
Okay, sounds good.
I'm sorry. I'm sorry. Were you going to say something, Erica? Did I cut you off?
Oh, no, you're fine.
Okay. All right. So I think that's all we needed to know. We appreciate that. That's going to be very, very helpful. And if Senate Bill 2 passes, there will be a requirement for KDE to have that information and to report it on an annual basis to the state Board of Education and also to the Interim Joint Committee on Education. So, and I assume that you all are you coordinating with KDE now, Erica?
Yes, we are. There's several different projects occurring. There's several different projects occurring, so we're collaborating with KDE. Daily, we're meeting on the different initiatives, and one of those being tracking the mental health services.
Great, great. Because that's something that the legislators and the school-based people and the advocates are all very interested in. So wonderful, thank you. You all probably know that the session is still going on. Some of us are tired of trying to decipher the budget. Let me touch on a couple of things, and then Steve, if you or some others want to add. I mentioned Senate Bill 2. There were actually two bills, House Bill 35 and now Senate Bill 2, to take the School Safety and Resiliency Act that was passed in 2019 and then updated in 2020. So it was Senate Bill 8, and try to bring it alive a little bit more. So those districts had to release their plans, but it was a one-time static thing, and we've made that an annual report. We've revitalized the trauma-informed team in the school and asked them also to address resiliency and well-being of all the students. So taking a more preventive approach as well as concentrating on students who have a trauma history. Very significantly, that bill has some excellent updates on the required suicide prevention training that goes on in the schools. That had not been updated, I think, since it was originally passed in 2011. So the school psychologists, school social workers, and school counselors, those three organizations came together actually a year ago and wanted to have a bill to improve that education in the schools. And so we put it into House Bill 35, and then Senator Wise incorporated it into Senate Bill 2. So if that's passed, what'll happen is that instead of just having one training in September, early September for the students, there will be a second training when the students return from the holiday break in December and early January, because the stats are that that's a very vulnerable time for students coming back into the school setting. We will also have that training to include the all of the staff, certified and non-certified school personnel, working with 4th and 5th graders. Unfortunately, as you all know, we've had some suicide attempts and also some completed suicides among some really young kids that were in 4th and 5th grade. So they're taking it down. And there's also a requirement that all of that training has to be evidence-based. And I think most of the schools were trying to do that, but there were a couple of school districts that were kind of handing out a flyer to a kid when they got on the school bus at the end of the school day. And, you know, we really want to save some lives. So
You froze up, Sheila.
oh, I don't know. Well, let me stop my
You're good
video.
now. You're good. You're back.
Okay. All right. Thank you. So, oh, it says I'm unstable. My internet connection.
I won't comment.
So, the other thing is that they will be gathering all of that data. They will be keeping track of the getting closer to the 1 to 250 for the mental health person in the school to the student ratio. So that's an important bill. The budget is House Bill 6. It just passed the Senate, and there were some significant changes in funding. I think I heard from somebody that the Medicaid funding was better in the Senate version than in the House version. Some of the school funding is not as good. They're not paying for 100% of transportation costs in the Senate. I think there was a lot of concern that there was not funding for affordable housing, which is one way to address our homeless concerns. And there was not sufficient funding for the child care cliff that's coming in September when all of the federal funding runs out. I know that the school superintendents wanted more money so that they could give raises for teachers, and neither the House nor the Senate bill puts that money in. So stay tuned, because they'll be locking themselves behind closed doors here in a couple days, probably for the next 6 or 7 days, to work out the differences between the House and the Senate budget. House Bill 56 is a mental health workforce bill that has the social work compact and also has some provisions for psychologists at the master's level to be able to begin practicing earlier in their career. And it's due to be voted on in the House. It's come out of the, I'm sorry, in the Senate sometime very soon. You've probably heard a lot about House Bill 5, which is the Safer Kentucky Act. And a lot of mental health people are very concerned, particularly around the way that the homeless are being treated in this. They're really being criminalized. And of course, a number of people that are homeless have behavioral health issues, as we know. There's also concern about the way that drug trafficking, providing fentanyl, for instance, to someone may result in people being less willing to call for help if somebody overdoses for fear of being prosecuted. So there's lots of concerns about House Bill 5. And even though this is not a behavioral health issue, I will draw attention to House Bill 367 that will significantly make it harder for people to be getting SNAP or food stamps, particularly elderly. It could really do significant damage to the free and reduced lunch program in schools. Really feels like warfare on the poor. Anybody have anything else? Oh, you want to talk about Senate Bill 71, Steve?
Yeah, that was reported out of committee. Initially, that bill was in the Senate, that a similar bill in the House. Senate Bill 71 requires residential substance use treatment providers to transport individuals who voluntarily leave the program. And either transport can be provide direct transportation to their home county, even their courthouse, provide for transportation, Uber or Lyft, or even a bus ticket. And several things were added to it today. One was a 202A provision, involuntary commitment, that would have to be done within an hour. And then there was an assessment every 10 minutes was 5% reduction in the rate received for the 202A evaluation. You know, it's not really a Medicaid issue, but it's pretty significant. The 202A evaluation done by CMHCs. We have since heard from Chairman Hebron of the committee. They're going to take the 202A language out of that legislation, but it's still the transportation issue is a legitimate concern. And we've met, and other folks I'm sure have met as well on both. Also, they've added a Medicaid. There's some concern some providers recruit people from out of state. They come to Kentucky, they become Medicaid eligible, and they use that address. So they're trying to address that problem. But the transportation piece, I think, could be an impact on access to services, because a residential provider may be hesitant to take someone who is, you know, a farther distance away than they wish to transport the person. You know, if someone has a program in Northern Kentucky, they may be reluctant to take someone from Bowling Green and Warren County, because that's about 3.5, 4 hours. So they're going to say no. So does that decrease access? The rationale for the bill is the impact of some of these programs, people just leaving the program. They've added recovery housing to it, and the drain it takes, the increase in homelessness. Legislators have been told by constituents, increased drug use by these folks that leave, as well as impact on social service agencies, homeless shelters, food banks, and things like that. So we've been told that the 202A language was added this morning at the 9 o'clock meeting will be taken out of the bill. And then they will still proceed as is. Still have concerns about it. It should be noted that the bill passed the Senate without a single senator objecting. They were all yes votes. The bill in the House Bill 408, passed the House without a single no vote, 98-0. So there's clearly an impetus from local communities that this is a problem, a concern. Senator Wheeler from Pike County, he sees it. He says he sees it for folks coming from West Virginia, crossing the bridge into Pike County. It impacts Somerset, E-Town, Elizabethtown has a huge number of folks who are just kind of leaving treatment or recovery housing and staying in the community or recovery housing using resources. So we'll see. Hopefully we see it would have to be a House floor amendment, unless they send it back to the committee, but they can do a floor amendment to take that language out. Kind of interesting, you know, reduce the rate, you know, by 5% for every 10 minutes, not done within an hour. Regulation is you have 3 hours to do the evaluation. Now they're going to put it an hour in. the payment mechanism. There's not a fee. It's not done that way. So, but hopefully this is an improvement. We're still concerned about the transportation piece. And I really do think that will have impact on access. Some folks are going to say, no, I don't want to take someone that's 3 hours away. So.
Thank you, Steve. Any questions or anybody else have any behavioral health bills that are of interest to them? All right. Any recommendations for the MAC meeting on March the 28th? Hearing none, we will not make any recommendations. Agenda items for the May meeting. Remember, it's May 1st. We'll have the BH rate change study. If we have time, we'll also schedule the school mental health services report. I think it would be helpful, Mary, that I guess is the day that the spa therapy services are starting. So it may be that we want to wait until the July meeting to kind of look at what's happening there. That'll almost be too soon to do it. But we will put that on for July. Is there any?
I agree. There'll be no way to know till the July meeting.
Yeah, we'll put it on for July. Any new business? All right.
I just wanted to say that we've been making calls like crazy about Tim's Law and mental health and drug courts, and I'm assuming that the Senate hasn't even, I mean, has it made any difference that we can tell so far? Probably not.
I do not think so.
Yeah,
I mean,
that's unfortunate.
They've
Yeah.
had to have green slips this high.
I think AOT's back in the Senate, right, Steve? Yeah, the
I
funding.
looked at it.
I think it is. I think it did make a difference in the Senate version for AOT.
Okay.
For Tim's Law.
Yeah, it's back in.
Tim's Law, yes, Tim's Law is correct. Right. But it's the mental health drug court as well. And I think the Senate version of AOT was actually an increase over the House. Is that correct? $500,000 a year? That's the Julie Rocky Adams initiative, I suspect.
It was a big increase.
A big increase. I'm sorry, a big increase for the AOT for Tim's Law.
Yes.
What's the number now? Is that David's husband that's on?
Yeah.
Yeah, it's 2.5 million in 25 and 3 million in 26.
That's right.
Wow. Great.
That's good.
Statewide implementation. Yeah, that'll allow more statewide implementation.
Yes.
Yes. Oh, that's Alan too. Great. Well, that's the best news I've heard today.
Me too.
Yeah.
Green
So
slip.
you
Yay.
can go back to your folks, Val. I know that you all were at participation station in NAMI Lexington. We're really getting that out. Several of us were at the NAMI Louisville dinner on Monday night, and
Yeah.
Judge Stephanie Burke made a
was
strong pitch there to get the word out. So I had sent that out.
And the House budget didn't have any for Tim's Law.
Didn't have any.
Uh-uh.
Good. I think that the thanks go to Julie Rocky Adams on that.
Yeah, we started pushing it when when it was in A&R.
Yeah. But she's been, she carried the bill finally when it was successful. So we should get some thanks out to her. Make sure that it stays in the budget conference. But
Tell me again how much it was.
2.5 million in 25, starting July 1 of this year, and then 3 million in 26, which starts July 1 of 25.
Okay.
So 5.5 million over the biennium. That's great.
Yeah.
Okay.
Yeah. Wonderful. Best news I've had.
Yay, me too.
Is Kathy Adams on? I think you had a question.
Her hand's
Kathy.
raised.
Okay.
Hi, Sheila, and I'm not sure if this goes under new business or yeah, or the old business related to TCM. But we've discussed over the last year at least concerns regarding the number of audits coming from the MCOs. And our members are again raising concerns and basically said they feel like they're just being inundated with audits again. They're reporting a lot of prepayment audits and post-payment audits specific to targeted case management services. And I can give you some examples, but also they're reporting a significant increase in the number of just prepayment audits in general. And one of the things with the prepayment audit is that it appears to be a way to circumvent the fact that there's no prior authorization being required for behavioral health services. So this seems to be a way to delay paying for services that have already been provided. And it takes, folks have already provided the service. They have staff that they need to pay. And yet the MCO is saying, we're not going to pay you until we complete our prepayment audit. And then I'm not sure if Medicaid tracks the prepayment audits that the MCOs conduct or not. But it seems like a way to keep from paying or reimbursing providers for services that they've already provided. Are they required? There doesn't appear to be any penalty to the MCO if they've withheld these payments for months from providers if no issues are found in the prepayment audits. So definitely that is a concern. And again, I've collected examples from our members. I'll give you just a couple of quick examples, or at least I hope I can. So we have one member right now that's getting an audit where an MCO is conducting a prepayment audit of all of their TCM claims for the months of November and December, which means then they'll put a hold on anything forward. So they're not getting paid for any of the TCM services that they've provided since November. Another example from another member is a prepayment audit of all of their intensive outpatient claims, which I believe was a 3-month time frame where they were requesting audit materials. And then the member that is going through the TCM audit prepayment for November and December just got another post-payment audit request from another MCO for a full year of services for 50 members. We also have another member that just got a post-payment audit for TCM where they're reviewing 515 claims for 49 clients. And the letter from the MCO is that they're going to deny all of those claims as the post-payment audit. It's kind of like they've extrapolated and not reviewed them all, but going ahead and penalizing the agency and withholding are going to take back all of that money. And then, if they appeal and win, then they would get some of that back. But so those are just a few of examples. I have more, and I just was curious if other providers are seeing an increase in the audits, especially for TCM, especially prepayment audits. And then also curious to know if DMS has any kind of mechanism and oversight of the audits that the MCOs conduct, especially those prepayment audits.
Communicare has received prepayment audits for our peer support services.
Kathy, this is Bart. I want to reinforce everything you said. I'm hearing a lot of the same things from some of our clients in terms of those audits. And I think the extrapolation, you see a few claims that they may deny, but it's the process of just denying every claim. I think clearly there could be examples where there's a lack of documentation on a few, but not everything that was audited. And I think that's it's ratcheting it up to just taking a few and extrapolating it out that it's 60 claims, 60 clients and for whole months at a time. And it's having a real negative impact, especially on the smaller providers. So I appreciate you bringing it up. And I just wanted to reiterate that we're seeing the same thing here. I'm hearing a lot of the same.
Thanks, Bart.
And I see that Rebecca has this from Isaiah House. We're receiving numerous prepayment audits for H0038 and H2027 from one MCO in particular. I know that audits are required by CMS and DMS, but it's really maddening, I have to say, when it comes up around targeted case management so often. This is what started us down the road when the commissioner was on, Steve, 2 years ago, 2.5 years ago.
It's been a target of the MCOs for
years. And we did the
10
study
years.
that showed that it really is a worthwhile service and keeps people out of the hospital and actually has a lower mortality rate and all kinds of things. And I guess my question, and I don't know who to address it to, so if Veronica is still on, if Leslie.
Yeah, I'm on.
This kind of extrapolation really bothers me. And I did hear this from a hospital recently, now that I'm thinking about it, where they found something wrong with one of the claims and threw out the whole batch of claims for multiple patients.
So I guess just to address a couple of things, and maybe perhaps, because I wasn't prepared to talk about this today, we could talk about prepayment and have the MCOs talk about their process, and DMS can talk about what the requirements are. Our contract, effective January 1, 2024, requires MCOs to get pre-approval from DMS before they implement a prepayment. And we changed some of the requirements because we were hearing a lot of complaints about it. And so I guess we can't enforce a contract when we don't have clear examples of violation. And so I appreciate you, Kathy, bringing up a lot of examples, but I don't know, have those been sent to us to investigate? That's the next step, is providers need to reach out to us if they believe that the MCOs are doing something they shouldn't be doing, so we could actually investigate it. Prepayment review does not mean that they can just blatantly waive timely payment. There are some nuances to it. If there's a back and forth to the provider to get the information that's necessary, they should not be extrapolating. And so, if there is an example of an MCO extrapolating a denial from an audit, then we need to know that and investigate it. We understand the administrative burden that comes with it. The TCM in particular, I just want to remind folks that HHS, the Health and Human Services federal agency, investigated Kentucky Medicaid for targeted case management. And as part of that, based on their findings, not ours, their findings, we had to enter into a corrective action plan that requires this cadence of auditing that you all, I understand, feel like you're under scrutiny for, but we were required to do that. So that's unfortunate. The abrasion comes down to the provider level, and I promise you, we're not trying to create administrative burden to providers. We want to get it right. Auditing should be for a specific purpose because something's been identified. that just needs an extra review. And whether that's prepayment or post-payment, there should be some underlying reason why the audit is occurring. So I'd love to continue the discussion on it. Happy to. Again, we could kind of walk through in a future meeting what the prepayment requirements are for managed care organizations. And then, if you want to hear from each MCO about their process, but please send us examples. We need to know.
When did that HHS investigation take place? It's the first I've heard of this.
In 2021,
Okay.
2020.
Veronica, this is Leslie. So when
2021,
when I got back in 2020, a state audit had already been completed, not us, state auditors for Kentucky, and that spurred the federal audit. And then that ended up in a rotation of 3 states and 3 federal audits regarding the same. And that one had just been completed when I got back in 20.
Thank you. Yeah, I again, not prepared to talk about it, so I can't even remember what I did yesterday. So trying to think
Totally
back to
get it.
2020 or 2021, but and that's a public document. Happy to share that
Yeah, it'd
audit
be
with
nice
you
to
all,
see.
so you all can see. I was almost certain that in working with providers and implementing the auditing for this, that there was an awareness of the audit and the reason we were doing this as part of our corrective action plan. So not trying to be secretive or non-transparent about it. I thought providers were aware. Now, providers change, and if you're like me, I can't remember what I did yesterday, so that could be. But just to try to make folks understand that auditing is required. It's not meant to be burdensome, but it's a necessary evil that we have to navigate.
Yeah. And we had several conversations over targeted case management previously here, and we kind of looked at did a little analysis of it, and it wasn't mentioned then. If it is, I missed it. I mean, I'm not critical. I'm just surprised. And it would have, I guess I suspect Kathy Adams didn't know that had taken place either, right, Kathy?
Well, I can't agree with you on this one, Steve. I was aware
Okay, good.
that there had been, that CMS had come down on Kentucky. I don't remember what format where we discussed it, but it's been a while since it was discussed. And, I think part of it is you like to think, okay, well, we're out from under that now, but apparently we're not. And I'm not sure when we get out from under it.
Yeah. If they increased recently, then why was it a 3-year delay from 21 to 24 for the MCOs to start looking at it? You would think it would end at something.
I think we've been hearing about TCM audits for 3 years,
Yeah.
to be quite honest with you.
Yeah. I don't think it's.
Absolutely.
I think so too.
I think
Veronica, to address something you said in regards to sending the information, this is the first I've heard about the fact that their contract they're required to get pre-approval for prepayment audits. So are you saying any of our members that have gotten prepayment audits should send those in to be reviewed?
If you have a question about it, if you're questioning, the activity, the implementation of the prepayment audit, if you believe they're doing something they shouldn't be doing, providers should report that on up to us so we can take a look.
And then a follow-up question, when they do, are they provided feedback? Because I feel that sometimes our members feel that it's just something else to do and nothing's happening as a result of taking that additional action.
Sure. In terms of the outcome of the audit?
Or hearing back from DMS when they submit those concerns that, we've looked into this and this is what we found.
Oh, absolutely. So there is lots of conversation as concerns are identified by providers about the audits, there's lots of conversation that goes on internally, just internally within DMS and including our Division of Program Integrity, and then with the MCOs to talk through making sure that, you know, we don't want audits just for audit's sake. They need to be truly, their direction is to identify fraud, waste, and abuse. And so, you know, just making sure that we have conversations all the time. If maybe they're auditing on something that is not causing as much concern as something else, for instance. So we talk about, well, then, you know, is there another area in the Medicaid program that needs more attention for identification? Because we monitor those trends all the time, almost on a daily basis, to try to, which is a requirement for our Division of Program Integrity, is to continue to monitor and identify and recoup if necessary, based on federal law.
This is Stuart Owen with WellCare. I just want to note, the MCOs get letters from DMS charging us with auditing specific providers for TCM, along with an FAQ of all the things we have to check for regulatory requirements. And it goes back to the audit that the Senior Deputy Commissioner is talking about, the CMS audit and the state audit. But we get letters from DMS saying you need to audit this provider and report back findings.
And what
got a
generates
question.
those letters, Veronica?
I'm sorry?
I say, what generates those letters that Stuart's talking about?
I'm not involved in that process, so I'm not 100% sure.
Okay.
Yeah, I believe it
But-
comes
but
from Division of Program Integrity.
Yeah,
I
integrity.
believe they do
It comes from program integrity along the line of the audits. Then they started pulling in our responsibility with the MCOs regarding targeted case management as well. So then, this has been a while, Angie Parker at the time was involved, and then program integrity had to set up an approved outline of how they would do regular audits and how many they would pull and things like that, and to come into compliance. So it ended up being 3 different areas of Medicaid that ended up working on these audits.
Well, let's do this, and I appreciate you all giving us this information with not knowing that this was going to come up. I don't remember ever hearing about the HHS discussion and you know, that kind of federal. I remember a discussion, because we've talked about audits a number of times on the BH-TAC. I remember a discussion where you know, it was made clear that CMS wants audits to happen and the state wants audits to happen, but I don't remember. But at any rate, why don't we put this on the May agenda? Because I think this is an issue that's of great concern all the way around. I think we need to understand the history would be helpful. Would be helpful to know what the parameters are for those prepayment audits to be approved. And I'd really like to understand from program integrity how these letters get generated, because that feels like a very different kind of target on providers. And I'm not saying it's not warranted. I'm just saying it feels very different than an MCO deciding on its own.
Dr.
to-
Schuster, this is Kelly.
Yeah.
Medicaid.
I'm sorry.
This is Kelly Seats with Medicaid.
Yeah.
And I just wanted to let you know that I've got a message from Jennifer that she did have another meeting at 2:30. So I'm going to make sure that she is prepared for this at the May meeting.
Okay, that would be wonderful. Thank you.
She's with Program Integrity.
Jennifer Dudinsky is our director for program integrity.
Oh, yes, I remember, because she's been in these discussions before. I know that name. Yeah.
Yeah.
So
Yeah. And
would you-
Sheila,
yeah.
yeah, just along those lines, I think that that would be helpful in that discussion from the program integrity is when a provider identifies, extrapolating and identifies problems and shares specific examples with them, what's a reasonable process or timeline to hear back on that? Because I think that we've run into that and have raised these issues, but still many months have gone by. We really don't hear anything back. And so not that, and I'm not saying DMS is not working on it. I know that. I'm not trying to throw you under the bus on that. I know it's a bandwidth issue, and I know you're working on it, but I think from the provider perspective, they're still kind of left hanging, and what are we going to do about it? So I know. So I think understanding better what the process is on the program integrity side will be helpful. So if that could be part of that, what Jennifer shares, that would, I think, would be helpful. So we're compliant with it.
Okay. And is that where the, when you say, Veronica, let us know about these problems, would it be most appropriate that they go to program integrity from the providers?
No, I recommend the provider complaint process through our managed care compliance.
Again, Dr. Seuster, it's Kelly Sheets again. I just wanted to let you know I'll be sending out information on how to make those complaints as well as the forms and where to send them to in the follow-up email that comes after this meeting.
Great, because did you send those out recently, Kelly? Was there a provider complaint form that was circulated recently?
Aaron sent them to another TAC. I don't believe it was this TAC. I think it was a different TAC.
Kelly, I sent an email blast to all MAC and TAC members with those attachments, but it's been several weeks.
Yeah, and it's hard to, and I really didn't know what the context was, so that's helpful. Let me do this. Let me get some feedback from several people that have spoken up here about some of these issues, and let me kind of outline what we would like to have discussion about in the May meeting, and I will get that to DMS, and you all can disseminate it to whoever. You mentioned 3 different departments or divisions, I guess, Leslie. But let me do that, and I'll get it to you, Veronica.
That'd be great.
Okay, let's do that. So let's put that on the, Erica, we'll do the school data in July. We're obviously not going to have time in May because we've got the behavioral health rate study, and then we really need to have this whole audit discussion. I think has been a vexing problem for a while. Maybe we could solve it like we did the dual eligible. So thank you all very much for, thank you, Kathy, for bringing it up, and for others who had concerns. And thank you very much to the DMS staff in all the different areas for responding. Last item, any formulary issues that anybody has? I always figure no news is good news.
Right.
Yeah. Okay. So the MAC meeting again begins at 9:30, and that's in 2 weeks, March 28th. And then remember that our next behavioral health TAC meeting is going to be on a Wednesday, and it's May 1st. And as an O'Donnell, I have to wish you all a very happy St. Patrick's Day on Sunday. Whether you're Irish or not, it's a great day to pretend like you're Irish. So I wish you lots of love and luck. That's what the Irish wish. So thank you all. And thanks again to Aaron and Kelly for getting us up and running today under some very difficult circumstances. So
you now Dr. Colonel or Colonel Doctor?
Yes.
Which one is it? Colonel Doctor or Dr. Colonel?
I don't know. Some of you may not know that I was surprised with a Kentucky colonelship from the governor at our disabilities rally. So, oh, TJ, if you're still on, NAMI Louisville Advocacy Day, you put something in the chat.
Yes, NAMI Kentucky's Advocacy Day will be next week on the 20th, Wednesday, and 10 to 11:30 in the rotunda for our rally, and then we're going to have lunch over in the annex after that. Hope everybody can attend.
Yes, I'm very sorry I'm going to be out of town and miss it, but thank you for letting us know. Yes, you don't have to call me Colonel. Actually, Secretary Freelander said that I was really a general and not a colonel, so I don't know. We'll see. Thank you all very much, and thanks for that announcement, TJ. So appreciate you all, and let's remember our dear departed friend Mike Berry in our prayers and thoughts, and his family. So I sent out the funeral information is this Saturday over in New Albany. So thank you all very much, and happy St. Patrick's Day. And we'll see you in May.